Welcome to this PCR Valve e-courses 2020. Today we're going to discuss how to optimize your TAVI procedure during the COVID-19 era. My name is Lars Søndergaard. I'm an interventional cardiologist from Copenhagen in Denmark. It's my pleasure to be here today with Dave Smith, also an interventional cardiologist from Swansea in the UK, and Didier Tchetche from Toulouse in France. So we all have faced a very difficult time during this year due to the COVID-19 situation. There's a very hard demand to try to simplify our procedures and limited the resources needed. And we're going to spend this next 60 minutes to discuss this, how to minimize resources needed for your TAVI procedure, of course, without compromising safety and efficacy, and also to demonstrate how to simplify your TAVI procedure. And then we're going to discuss considerations for lifetime management of your patients with aortic stenosis. The symposium is going to be structured like this. Didier will talk about access considerations for your TAVI patients. Then Dave will tell how to optimize procedure efficacy. I will talk about lifetime management of patients with aortic stenosis. And finally, we're going to see a recorded case from Toulouse. So maybe, Didier, you can start off here to tell us about your consideration when you're planning a patient for TAVI.
Okay, thank you very much, Lars. So access considerations for your TAVI patients. Here are my disclosure. So the main consideration that we have when we move for a transfemoral procedure is to prevent vascular complications, because we know that vascular complications, when they are major, they are going to impact the bleeding rates and, as a consequence, the survival of the patients. It has a negative impact on the survival. So we should try to prevent these complications. And we also know that the sheath size, or identified by the sheath to femoral artery ratio, plays a role in the occurrence of major vascular complications when we have more than 5% of greater diameter of the outer diameter of the sheath as compared to the inner lumen of the vessel. This is going to impact the vascular complication rate. So we have to keep this in mind. Another point is to try to achieve a proper common femoral artery puncture, and this goes through a thorough assessment of the characteristics of the vessel at baseline through MSCT, with namely assessing the size, the tortuosity, and the calcification of the vessel, and also making sure that we still keep that sheath to femoral artery ratio below 1.05. And the goal is really to target the anterior wall of the common femoral artery. But this is a standard practice for all the heart teams. So we have various techniques to get access to the common femoral artery, whether it be a fluoro-guided puncture, it can be through identifying some lead marks, using a clips, injecting contrast through the needle, using a contralateral pigtail. Whatever technique you use, even the micropuncture, the goal is always the same: safe puncture, anterior wall, mid portion of the anterior wall of the CFA. I'd like to say that in a more contemporary practice, there is really more and more interest towards echo-guided puncture. And echo-guided puncture seems to be a probably better way to get access to the vessel, because it's really easy, as you can see here, to identify the location of the femoral bifurcation. If you rotate to the short axis, you can see that bifurcation. And if you scroll more cranial, you're going to get a more visible location of the common femoral artery. So this is definitely something that is going to make it easier for you to get that stick to the within the common femoral artery, the anterior wall. So very easy. So after we get the access, we have the opportunity of using various closure devices. There may be subtle differences between these closure devices, whether they be suture-based or from other technology. There have been attempts to compare these closure devices, but more roughly, you should use the one that you master and understand more about how it performs and the tips and tricks that you may use to increase its efficiency. we have, in that sense, some better understanding about how to use a ProGlide, and there are a couple of tips and tricks that we may use, namely keeping that 45 degrees angle, first for the puncture and second for the deployment of the ProGlide. And at last, that's something that we've integrated in our daily practice in Toulouse. Once you've deployed the sutures across the anterior wall of the common femoral artery, it is standard practice to pull on the strings to remove the slack. You keep both strings parallel, and just by pulling on them, you will remove the slack from within the vessel, increasing the efficiency of the closure at the end of the procedure. There is another device. It's a plug-based device, the MANTA device, that has been compared in several studies to the ProGlide. It seems to provide the same frequency, same rate of major vascular complications. So it's really about what you feel more comfortable with to use during the procedure. Various closure devices, more or less the same efficiency. So what we also know is that preventing major vascular complications goes also through getting a secondary access that is going to avoid this 1/3 of vascular complications related to the accessory side. And that's why there is now a trend to move from a bifemoral access to more a one radial and one femoral access, because we know from the PCI experience that the radial access prevents bleeding and major vascular complication as compared to the femoral access. So if we come back to the shift to femoral artery ratio, it's obvious that the type of device, the catheter that we're going to use, is going to impact the vascular complication rates. And I'd like to say that the FlexNav, as it is right now, with this 14 to 15 French profile and the really improved profile, the integrated sheath, the stability layer, and a very flexible catheter, has the ability to prevent this major vascular complication rate. And this has been translated within this global FlexNav registry with 180 patients. And you can see that the major vascular complication rate was way below 10%, 5% in this cohort of patients. So really the FlexNav seems to have a positive impact on the vascular complication rate. So at last, the ultimate goal from an access consideration point of view is to make sure that we prevent any complication and we have an early discharge of the patient. And this goes from early ambulation, and the goal is to discharge the patient 2 to 3 days post-procedure. So what we do is to, as usually, go for conscious sedation, 30 minutes after the procedure, making sure that the patient is awake, 4 hours after the procedure, getting the patient sitting on the chair, and at last discharge on day 2 or day 3 after the procedure. I would like to say very simply that preventing vascular complications is key because it positively impacts the outcomes of the patient. It goes through a thorough analysis of the vascular anatomy through MSCT, securing the femoral puncture and closure, and certainly the echo-guided puncture is one of the ways to go in the future. Very low rates of major vascular complications are achieved with the FlexNav system, and this is a real improvement that is going to be beneficial to our patients. And at last, early ambulation and early discharge could become the default strategy. Thank you very much.
Thank you, Gigi. That was an excellent talk on access considerations. And I would just remind you as an audience, you have the opportunity to use the chat function to post questions and comments to this, and we're going to address that at the end of this symposium. So Dave, we all know that everyone is pushing to do their procedures as a transfemoral approach. Can you just try maybe shortly to tell us what is the reason we want to do this procedure as a transfemoral approach?
Yeah, it's a very good point, Lars, isn't it, that we know from the totality of the evidence that we have, certainly comparing TAVI to surgical aortic valve replacement in the randomized controlled trials, that the main benefit of TAVI over SAVR is in patients who can undergo TAVI via the transfemoral approach, and certainly without the use of general anaesthetic and avoiding alternative access, the more patients that we can perform TAVI on via the femoral route in a minimised approach is certainly going to be what we desire. And I think that the FlexNav system and its access considerations that Didier has described certainly allow more patients to be treated via transfemoral access.
Yeah, I think that's one very important iteration we have seen for many systems during the last years, to try to lower the profile of the system using expandable sheet, or as you've seen here with the FlexNav system, integrated sheet. So you bring the size of your delivery catheter down by 4 French. And that, I think, in combination with this very flexible system, is opening up for more patients who can be treated by a safe transfemoral approach, and thereby minimize the risk of vascular complications. So let's move to your talk, Dave. Try to explain how you in your institution is optimizing the procedural efficacy.
Okay, thanks, Lars. So my name is Dr. Dave Smith. I'm an interventional cardiologist at Morriston Hospital in Swansea in the UK. And I'm going to talk about how we optimize the procedural efficiency of our TAVI procedures during the COVID-19 era. These are my conflicts of interest. So what do we actually need to do to achieve increased procedural efficiency during the COVID-19 era? Well, clearly we want to perform safe, effective and efficient procedures in the current era. We want to, wherever possible, minimize resource utilization, and from the patient's sake, try to minimize their stay in hospital. So I think there are 4 ways that we can actually do this with our delivery systems. We need a delivery system that's both easy to handle, prepare, load and use in the catheter lab, and that's for the whole of our catheter lab teams. We need a TAVI system that allows accurate and predictable placement of our valve, hopefully facilitating first-time valve implantation without multiple repositioning. We want to facilitate, wherever possible, high implantation locations to reduce conduction abnormalities, and particularly the use of permanent pacemaker implantation. And looking somewhat to the future for the durability of the valve, we want to, wherever possible, optimize hemodynamic valve function with large effective orifice areas, low gradients, and minimal paravalvular leak. In terms of preparation of the valve, the new FlexNav delivery system is a very easy valve to handle, prepare, load, and ultimately deliver in the human body. It only requires normal saline to rinse the valve for 10 seconds on 2 occasions, and the whole procedure of handling to loading can be achieved within a few minutes, which is certainly a good thing for our catheter lab teams. In terms of the accuracy and predictability of valve placement, this is a video of the 2 systems, first generation on the top, FlexNav delivery system on the bottom, being simultaneously deployed on the table of my catheter lab. And what you can see with the reference point of the scissors there is that the first generation valve has a tendency to dive, in this case from right to left, or as we know it in the body, into the left ventricle, whereas the FlexNav system is both smoother to deploy, but also ensures that stability of unsheathing and therefore positioning within inside the native aortic annulus. If we translate this into procedural effectiveness and efficiency, you can see that this allows for stable and accurate valve deployment and implantation within the human body. If we utilize this feature of stable deployment and accurate deployment together with the now widely used cusp overlap technique, it means that we can actually allow for accurate placement of the valve in terms of depth into the left ventricular outflow tract. On the top 2 panels, you will see a 3 cusp and a 2 cusp CT view of the aortic annulus. In the two cusp view, we obviously have overlap of the right and non-coronary cusps, with the left coronary cusp on its own. And if we look at the pictures of the left ventricle on the bottom, and we look particularly at the left ventricular outflow tract height, you can see that in the three cusp view, we have a very foreshortened left ventricular outflow tract, whereas on the right panel, we have a less foreshortened view of the left ventricular outflow tract. And these two attributes mean that we're able to accurately place the valve into the left ventricular outflow tract. This has been confirmed in the Portico IDE study, where we can actually see a virtual halving of pacemaker implantation rates using the same valve, but the two different delivery systems. If we also look at the FlexNav pooled analysis from the IDE study in America and Australia, together with the EU data, we can also see from this pooled analysis of 180 patients a reduction in pacing rate comparable with the IDE data. In terms of hemodynamics, we can see very effective hemodynamic data from this same pooled analysis, low mean gradients, high effective orifice areas, and this is maintained from 30 days out to 6 months in the recently presented data. If we look at the clinical outcomes, we can also see low rates of paravalvular leakage, and because of the high effective orifice areas, also a low rate of severe patient prosthesis mismatch due to that. So in summary, we can see that we have effective and safe clinical outcomes with the new delivery systems, low rates of pacemaker implantation, low rates of paravalvular leakage, and this is confirmed out to 6 months. And therefore, I would advocate that this allows safe, effective and efficient procedures with minimal resource utilization and hopefully allowing short hospital stay. Thank you.
Dave, that was an excellent talk here. So I will just once again remind you as an audience, please send your questions or comments with the chat function, and we're going to address it at the end of this symposium. So maybe I can just ask you, Didier, in your institution, first of all, in these COVID-19 times, and also as we're going to move to patients with longer life expectancy, what's actually important for you when you choose your transcatheter heart valve for a TAVI procedure?
This is a very important point, Lars. It's true that in this particular pandemic era, we may tend to offer immediately transcatheter procedures to our patients as opposed to surgery, in order not to overload the intensive care units. So we're going to treat younger and lower risk patients. So we have to make sure that the device that we select is going to be extremely efficient with no PV leak, that we may aim at early discharge. So a low rate of pacemaker is required, and that is of paramount importance. And I would say that as we will be forced to treat younger and low risk patients, we have to think about the future. And the future goes through maintaining coronary access for these patients, and using devices with open cell designs like the Portico is really important, to my opinion, because these patients are going to live longer. So we need to make sure that we will be able to get any kind of procedure required in the future. So no PV leak, no pacemaker, and importantly for me, access to the coronary arteries.
Okay, thanks, Didier. I think that's a very important insight into how we choose our valves for our patients, and certainly moving forward, even outside of the current era. So I'd like to now introduce Lars to talk about future considerations for patients undergoing TAVI.
Thank you, Dave. So I'm going to talk about a lifetime management of these patients with aortic stenosis. These are data from our institution in Copenhagen, looking at what the surgeons has been doing for the last 15 years. So if you look on the left-hand side, this was the surgical valve which was implanted in 2005 and 2006. The gray one is the one who is a bioprosthetic valve, and the black one is the mechanical valve. And you can see the age of break-even was 68. And less than 10 years later, it was 61 years of age. So you can see more and more patients will receive a surgical bioprosthetic aortic valve. And from what we have seen with the low-risk trial, we can expect that these patients in the future is coming for a transcatheter aortic valve replacement. But moving to patient with longer life expectancy is a very different game compared to what we're doing today. Up to now, we've been treating mostly patients who have a mean age of 80 years, and these patients probably have an expected life, have a life expectancy of 5 years. So let's say that the valve is going to last 10 years. Durability is not an issue because the valve is going to survive the patient. But as we do, as the surgeons are doing today, treating much younger patients, let us say patient is 6 years of age and he's still going to live to his 85. That patient got 25 years of life expectancy. So we can see we need to do multiple revalving during the remaining lifetime of the patient. And that's, of course, going to call for the best durability of these valves to minimize the number of revalving which is needed during a lifetime. And how to get good durability, I think, as Dave was saying in his previous talk, we need valves which have a large effective orifice area and a low gradient. We used to say that self-expanding technology with supinal position of leaflet was the best valve to have these features. But you can see here from the Portico IDE trial in the US that Portico certainly have a higher opening area and a lower gradient than the Sapien valve, the balloon expandable valve. But also if you compare to the Evernote platform, which have a supinal position of the leaflet, you can see Portico offer you the same opening area and the same low gradient. So today we cannot say that supinal position of leaflets is giving you a better hemodynamic outcome. It seems to be for all kinds of self-expanding technology, supraannular or infraannular leaflet position. Another issue in these patients who got a longer life expectancy is future access to the coronary arteries. And we can divide all valves up to 3 groups: low stent frame or high stent frame. And for the high stent frame, you can have an inside position of the leaflets as for the Portico, or for a supraannular leaflet position. And particularly for those with a supraannular position of leaflets, it can be very difficult to re-access the coronary arteries. This is a recent study, 300 patients, who immediately after TAVI procedure, they tried to access the coronary arteries, and you can see that it was unsuccessful in 7.7% of the patients. 23 patients, where 22 patients actually was treated by an Evernote platform. So again, supinal position of leaflets will make it more difficult to re-access the coronary arteries. But still, what we all need to aim for, no matter what valve we're going to implant, is commissural alignment. So we don't need the situation on the left side where the posts are placed in front of the coronary arteries. We want, as on the right side, to have commissural alignment, exactly as the surgeons are doing. That's going to make it easier to access the coronary arteries in the future. How can we do that? Dave was talking about using the cusp overlap view, the left-right cusp overlap view for your valve implantation to reduce conduction subnormality. But if you use that view, you're going to see that the commissure between the left and the right coronary cusp is going to be isolated on the right-hand side of your fluoroscopy screen. So you have one commissure here. So if you can place a post of your heart valve on that position, you know you have commissural alignment. And for the Portico valve, you have 3 taps, and all taps are sitting on top of a post. So the only thing you need to do before you start deployment in a cusp overlap view is to place your post. You can see that quite clearly on the stent frame on your right-hand side of the screen. If it's not there, you go a little bit up and down in the ascending aorta while you're rotating until you have it. And as you can see here, after deployment, you have a tap sitting here on the far right side of the screen in a right-left cusp overlap view, indicating that now you have commissural alignment. And if you want to confirm it, you can roll back to a right non-coronary cusp overlap view in an LAO projection. And then you know, in this projection, you're going to have the left main stem coming off on the far right on the screen, like here, because you have one post isolated on the left-hand side and 2 overlapping each other. And this is just illustrating it's very easy to, in that projection, to access the left main stem. So just here to conclude, if you want to take lifetime management into consideration, treating these patients with longer life expectancy, you need to understand that the durability of this fibrostatic aortic valve is really important. Self-expanding transcatheter heart valve seems to offer better durability due to the larger opening area and the lower gradient, and there's no difference whether you choose an intra or supra-annular position of the leaflets. And Commissural alignment is easy with some of these valves, particularly the portico valve, and that's going to ensure easy future access to the coronary arteries. Thank you.
Excellent. Thank you, Lars, for a superb presentation. And before we have some discussion, I'd just like to re-emphasize the fact for the audience that please do use the chat function to ask any questions. Lars, in your presentation as well as mine, we've talked about the cusp overlap view, and I know that it's gaining increasing prominence, but not every operator and cath lab are using it. Certainly from my perspective, we've talked about the ability to accurately place the valve in terms of its depth into the left ventricular outflow tract, and I think that clearly is important for trying to reduce conduction abnormalities and certainly pacemaker implantation post-TAVI. And I wonder if you would like to comment a little bit further on the use of the cusp overlap technique, with particularly the ariocaudal projection being used to deliver the two-cusp view in terms of the commissural alignment.
Yeah, that's a very good question, Dave. So everyone used to have this classical LAO projection where we do the TAVI implantation. But now people, as you said, moving to an ariocaudal projection or cusp overlap view, which is going to bring the C-arm towards that direction. And first of all, it's important because, as you also mentioned in your talk, it's going to elongate the left ventricular outflow tract, so you have a much better understanding how deep, how high are you during your valve implantation. And also, as I was trying to demonstrate here, commissural alignment is going to be critical, not only for accessing the coronary arteries in the future, particularly if these patients have a long life expectancy, but probably also for the durability of these valves to try to align them to the native commissures. And by using this cusp overlap view, you can actually tailor commissural alignment to each individual patient during your valve implantation. So I think that's where everyone needs to start moving towards.
Thank you, Lars.
Yeah, I fully agree with you, Lars, and I do believe that it's more a combination of the cusp overlap technique and the commissural alignment that makes sense, because if we are aiming high to decrease the conduction issues occurrence, what we may end up is with a very high implant. We may put some of the sealing system, the sealing cuff in front of the coronary arteries and increase the risk of coronary obstruction or difficulty to re-access the coronary arteries. So that's why this high implant through cusp overlap, to my opinion, should be systematically combined to a commissural alignment, just to make sure that we keep all the benefits of the platform, and we tailor the depth and the orientation of the posts to the patient.
We're going now to present this case of TAVI for, of course, severe aortic valve stenosis that we'll treat with a portico device. The patient we are going to treat today is an 85-year-old lady, quite thin, frail, who was referred for severe aortic valve stenosis, symptomatic with a shortness of breath and IOHA class 3. On her previous medical history, past medical history, we see an history of hypertension, deep venous thrombosis years ago, and a severe respiratory condition with FEV1 at 0.75 liter. She's a woman who lives independently at home with her husband, independent, so a good quality of life that should need to be preserved to our opinion. Laboratory investigations only shows a mild anemia without evident obvious cause, mild impairment of kidney function, and of course NT-proBNP that is quite high, as referred to her severe aortic valve stenosis. TTE shows severe aortic valve stenosis, aortic valve area 0.7 centimeter square, mean gradient 63 millimeter of mercury, preserved LV ejection fraction, no significant mitral valve disease, and moderate pulmonary hypertension associated with that. On the ECG, what is important to notice is that she has a right bundle branch block, and we'll discuss how we manage that in the setting of TAVI, of course. No significant coronary obstructive disease on the coronary angiogram. And what is the most important trying to plan a TAVI case is the CT scan analysis. So at the annular plane, you see that we have measurements that are showing an area-derived diameter of 23.3 and also almost consistent with a perimeter-derived diameter given the circularity of the annulus, also 23 millimeter. LVOT assessment 3 millimeter below the annular plane shows almost the same measurement, so a tubular configuration. And it's important to notice that we don't see any huge important calcification at the location of the annulus nor of LVOT. Sinus of Valsalva is quite large, generous. It's a tricuspid valve. You see on the right side of the screen the three-leaflet anatomy of this aortic valve with quite important calcification, predominantly on the left and the non-coronary cusp. And the femoral and overall arterial anatomy assessment is favorable for a transfemoral access with a good lumen diameters, no tortuosity, no major calcifications that could be a contraindication for transfemoral access. So here are the risk scores evaluation, but overall the art team assessment we made for this octogenarian lady with severe respiratory condition was in accordance, yeah, you can go to the next slide, was in accordance with the transfemoral TAVI, with on one side some features considering this patient at high risk, mainly the respiratory condition, and on the other side, an anatomical assessment that is totally favorable for a transfemoral TAVI.
As we routinely do for transfemoral TAVI cases, the patient has been put under conscious sedation with local anesthesia to get access first to the right radial artery for the pictal guide in the procedure, and second to the right common femoral artery for the ultrasound guided puncture. So we've put 2 proglides for preclosure, and the goal is to predilate that patient, that anatomy, because the level of calcification is quite high, as we saw on the CT scan that you nicely described, Nico. So we're going to use a 22, so it's quite it's close to be a 1-to-1 predilatation as in regards to the mean perimeter derived diameter of the annulus, slightly below. The annulus was 23.3. The balloon is going to be a nucleus 22. And we intend to implant a portico 27. Usually we tend to remain on the safe side for predilatation using the minor axis of the annulus at baseline, just to open up a little bit the leaflets and then avoid to be too aggressive at baseline before device implantation for the structures. But here, given the amount of calcium first, and second, given the fact that we want the device to fully expand once put across the aortic valve, it's going to be more towards a 1-to-1 ratio, 0.9 ratio, just to be a little bit more aggressive for this particular patient. But usually, it's true that we go for a more gentle pre-deal. So the balloon is across the valve. So as the team is ready, we're going to proceed. So pacing on. Okay. So Nico, you can inflate.
Balloon up.
And we see the movement of the calcium, balloon deflation, down, and pacing off. So 2 things here. First, the accuracy of the pacing was nice. Yeah. And second, we don't see yet any conduction disturbance.
No.
So we have 2 options for the portico. Either we go sheathless or we use a sheath to deploy the valve. Here the peripheral vasculature was favorable. So just to decrease the rate of vascular complication, let's go sheathless.
Yeah. So just at the level of the skin, Didier, you entered the nose cone and the distal capsule, and I think you told that it's important to emphasize what is really striking here is the hydrophilic performance of this tip of the catheter that makes it navigate through the vessels and the tortuosity really easy, and it's really an original feature I think we felt. This system has an inline sheath, so incorporated sheath that goes towards the capsule and that goes with the catheter. Here it's a 27 millimeter portico, so the profile at entry is 15 French. And then we have the delivery catheter with the handle, and I would say it's very, very simplified, simple design. You just have this knob to release the valve, but we'll see that in action. And here a locking button that prevents you from deploying the valve totally if it's not necessary, or if there are any reason for not doing that. But we'll see that afterwards.
Okay, cool. So let's proceed. So this is not a major tortuous vessel, but you see how nicely the catheter is able to advance and flex according to the anatomy of the patient. This is the only time where Nicolas, I think you pull a little bit on the wire.
Yeah, but not that much. Huh?
Okay, so we may zoom in, and let's try to see if we can work directly into the cusp overlap view. And so we see that we have, we put the catheter a little bit, the straight part of the catheter a little bit apart from the valve, so we should be able to see, because we can focus on the non-coronary sinus. Okay, let's inject. Okay.
Good. Didier, maybe you could comment a little bit before we start, because everything is stable, ECG, hemodynamic. You could comment a little bit about your landmarks, visual landmarks on the valve, and how you will define your depth of implantation.
It's true that this is very important. So we see the nose cone, and then there is an empty gap, an empty portion between the nose cone and the stented portion of the delivery of the prosthesis itself. And then there is the radiopaque marker. That radiopaque marker is not related to the stent frame, so it's going to move relatively to the stent frame. But this is the first marker just to position the device at the start. Here we have the issue of a risk of AV block, so we're going to be a little bit higher than we do usually. Usually you put that marker at the annulus and then you start the deployment. Here we're going to keep it maybe 1 millimeter above the annulus, keeping an eye on the distal edge of the stent frame. What is really important is that we don't have major parallax, so I think we can start to deploy.
Okay.
We don't need to correct the angulation yet. We're going to see once the device extrudes. And the goal definitely, once the device will be exiting the sheath, will be to go very slowly. Yeah. Nicolas is going to do that.
So you saw that I was quite fast now until we reach that point, and now the valve is going to flare, extruding from the catheter, and now I'm going really slowly to allow Didier.
And a complete AV block. Yeah. You can simulate at 60.
To allow Didier to fine-tune his position.
Okay. Max, okay, thank you.
Yeah.
So we see that there is there was a complete AV block before anything. So
and you see that it's totally reversible because we went out, and it's totally reversible. So maybe we could try to be even higher.
A little bit higher. Yeah. So let's resheath.
Yeah. So I'm resheathing in order not to be traumatic.
Okay. And we're going to start higher than that. Okay, so for the time being, we keep the backup pacing just in case. And we're going to see if we have a higher implant, close to 0. Okay.
And now
inject, please, Laetitia. Okay. Yeah. So let's try to keep it here. Okay. So far it remains high. So we're gonna.
The speed is good for release.
I like it. I like it very much. From time to time, I keep an eye on the
ECG.
The ECG. Yeah. Okay, let's make a pause here. It's going to expand, and we're going to inject. Okay. I think we can try here.
Okay.
And then we will analyze the conduction aspect afterwards.
Okay.
Okay.
So what is important and noticeable, Didier, with this valve?
Yeah, there is still the complete AV block.
Yeah.
Okay. That's resumed a little bit.
What is important and interesting with this valve is that it's, an intra-annular valve.
Yeah.
And Okay, good. We perfectly saw the stability it provides during the first phase of the deployment. And I think it's what important feature that is good, especially in such anatomy, because it provides more accuracy to position your valve, to fine-tune your position. So here, I doubt we can position it higher.
We can't be higher than that. So the in terms of preventing conduction disturbance by the depth of implant, that's the maximum that we can achieve.
I think so.
We're going to see if the conduction system recovers after the procedure. But in terms of depth of implant, it cannot be higher. One thing we have to decide is whether we think that there would be a need for post-dilatation.
Yeah.
If we think that there is a potential need for post-dilatation, we may have to position it a little bit lower.
Okay.
So let's put the right ventricular lead, please.
Here, as we anticipate, given the baseline ECG that we'll need, maybe pacing, I think it's wiser to put the right ventricular lead.
Okay, we're going to record just to see where is the angio. Inject, please. Okay.
So what is interesting to notice here is that although the valve is not fully deployed, the amount of leak is not significant.
It's almost zero.
Yeah. So considering the comment you made, Didier, I think we should not have to post-dilate. So I would be maybe happy with this depth and with this height of implantation.
So it's a small anatomy, so we're gonna just withdraw the pigtail to avoid to jail it. Oh, and now Nico, you can.
Yeah. So if you just focus also on the delivery catheter and the handle, you see that. Here I have this visual signal telling me that I'm almost 80% of the deployment.
Yeah.
And this, as I was reaching that point, this locking button went up. Okay. And if I want to manually go over this location, you hear that click. It's not possible. So it's a safety feature. And if I want now to deploy furthermore the valve, I have just to unlock this safety button and keep on deploying. So you happy, Didier?
Yeah, I'm happy.
Okay, and I'm going slowly. Huh?
Yeah, I like the way the way you deploy it, very slow, just to make sure that we control everything.
Okay.
So the blood pressure is recovering gently. And the goal now, we're going to focus first on the coaxiality, and second on the position of the tabs. So here we have 3 highlights or tabs that we need to release. So we can see 2 of them, and we see the 3 of them. 2 are on the side, and the third one is just in front of us.
Yeah.
And in terms, what's really interesting here also, I'm going to record that without contrast, is the commissural alignment. And it seems that the commissure is located towards between the none and the left of the device. So the commissural alignment for this patient is good. So here is the hemodynamic that we have. Hemodynamics. Let me flush a little bit. So no major gradient.
Yeah.
The LVD increased a little bit, but this is more about the. This has to do with the complete heavy block that she experienced, and the diastolic aortic pressure is more than 1/3 of the systolic aortic pressure. We see the diacrotic notch, so this is quite favorable. And let's see what we have. So virtual regurgitation, a very high position, close to 0 to 1. We see the nice constraints across the anatomy. I like it.
Yeah.
We see the filling of the right and the left coronary arteries. And portico device, given that commissural alignment, should be very easy to get access to the coronary arteries.
Exactly. Yeah.
So most of the time it's enough.
Yeah.
So the first proglide has been closed. There is no major bleeding. So what I propose is to remove the wire. Yeah. And I'm gonna complete the closure of the first one, and we're gonna decide if we need the second one.
And in case we would have had a more severe bleeding, what we used to do is to jail the 035 wire, and to add a third closure device on top of the two ProGlide. So it can be another ProGlide, it can be a collagen plug, depending on the amount of bleeding and of the choice of the operator.
Yeah. So we're set for the final angiogram. So here is the final angiogram. There is a small stenosis and a tiny residual leak, but this should be okay with manual compression.
Yeah.
So this was a very interesting case, Nico. Do you want to wrap up?
Yeah. So we saw a small, thin, frail patient with heavily calcified anatomy, allowing us to highlight the specific features of a portico device. So predilatation in that case, very accurate, safe deployment of the device because of the intra-annular feature of a valve mounted in that frame. Possibility to implant this valve really high. Good final outcome regarding the leak. Yep. We'll assess, of course, the pacing issues in the following days. Even though it was not illustrated by such anatomy, also a feature about the flexibility of a flex nav catheter that is really highly performing in adverse anatomy.
So let's discuss this, not only this case, but also this COVID-19 pandemic. So Dave, during those last 6-8 months, has your TAVI program been affected by that?
Yeah, as with many specialties, we've seen a reduction in the capacity that we have for delivering TAVI, but it's also meant that we've had to further streamline our TAVI service, and particularly our procedural considerations, to make sure that we minimize the duration of time that patients are actually in hospital for. So in some respects, it's meant that minimalist or rapid stay TAVI has had to become absolutely the default as to becoming an option. It's had to become mandatory.
So you're actually doing fewer cases now than you did before the pandemic?
Certainly in the first few months of the pandemic, our volumes dropped, and then we've now seen, because of the difficulties with our surgical colleagues, we've actually seen an increase in volumes. But what it's meant, because of the difficulties of screening patients for COVID-19 and trying to minimize their time in hospital, we've had to get more efficient in our TAVI procedures, whilst at the same time, hopefully, reducing the length of their stay and minimizing the other areas and stakeholders of potential TAVI procedures that may further delay a patient's stay in hospital.
So you also seen a shift from patient who in the past went for surgery, which is now coming for TAVI.
We've seen this year a big sort of cross-referral from our surgical colleagues of patients who are suitable for TAVI, who may have undergone surgery. So we've seen a lot of referrals from our surgical colleagues this year, because they clearly have been hardest hit with the need for ventilation, cardiac intensive care unit stay post-procedure. So in the first few months of the pandemic, we all saw a decrease in workload, but certainly from June onwards, we've seen increasing referrals, increasing procedures volume, and that does not show any sign of abating. And now that we're in a second wave of COVID throughout Europe and in the UK, similar to Europe, we are faced with increasing volumes of patients that we need to treat in a timely manner.
Is that the same in Toulouse in France, Didier?
Yeah, it's exactly the same pattern. We observed the same phenomenon. At the start, we didn't exactly know what was going to be the outcomes in terms of number of COVID cases and so on. So we had a drop, we observed a drop in the number of procedures. But what we are seeing now is more referral of typical surgical candidates, not the very young ones, but slightly younger than the ones that we are treating with TAVI. So this has a positive impact, because as these patients are younger and healthier, the TAVI procedures go extremely smoothly. And this is exactly the subgroup of patients that you can discharge the next day or 2 days after the case. So it tells us that we need that collaboration as a heart team, just to make sure that if we treat younger patients, because this is a good reason due to the pandemic, we have to observe exceptional optimal outcomes for these low-risk patients.
So Didier, what do you see as the main factors of a TAVI procedure that you have to focus on in order to have this, how should I call it, streamlined or fast-track TAVI with the use of a minimum amount of resources?
So I think the key aspect of a fast-track TAVI is achieving early ambulation for the patient. Early ambulation, so you need to make sure that you're going to get a safe access and closure to the femoral artery. So it should be, to my opinion, transfemoral TAVI first, if feasible. Securing access and closure, making sure that the patient can be awake early after the procedure. So this goes in favor of conscious sedation for the vast majority of the cases, with a very light sedation. And if feasible, the patient should be ambulatory, should be walking a couple of hours or at the end of the day after the procedure. And this way you can expect early discharge. So it tells it's also important to avoid conduction disturbances. And just to bring you back to the case that we saw, this lady resumed her conduction abnormalities the same day of the TAVI procedure, so we could withdraw the pacing lead the next day, and she was discharged a little bit later as compared to the regular patients on day 4, but without a need for a pacemaker. So we need to select proper patients, proper devices to make sure that we have early ambulation, no conduction abnormalities, because these are the main factors for prolonged hospitalization.
Okay. So just there's one question from the audience here regarding vascular access and closure. So the question is, how many closure devices do you need in your institution? Should you have several on your shelf, or should you just focus on master one closure device? Tchétché.
So this is only a personal experience, and it's based on our policy in at our institution. We like to try several devices and to try to figure out how they can improve the outcomes for our patients. So if I have to answer honestly to your question, I would say that you need to master one closure device to know everything about that closure device, but you need a second one at least to bail out some difficult situations if you have a failure of the first one. Because I do believe that if we go for more aggressive things like covered stents, like a surgical repair of the vessel and so on, this is not benign for the patients. So if you can bail out the situation with a second closure device that you know how to use, I think it's a good thing. So one is mandatory for sure. You need to understand 100% of that closure device, but get a second one to bail out your difficult cases.
So Dave, I think we all agree that it's important to get these patients mobilized as early as possible to bring them home. But also we know that one thing which often keep the patient in hospital is conduction abnormality. So what is the current trend to try to reduce the rate of conduction abnormality during a TAVI procedure?
I think, as you say, it's a very important point, and it's also bad for the patient potentially, and it also incurs increased use of other resources from our EP colleagues. I think the understanding of potential conduction disturbances starts with the first ECG when you review the patient. We know that certain ECG abnormalities at first review, right bundle branch block is probably the greatest example, but not the sole one. So we can already have a pre-warning of whether these patients are likely to need pacing up front before their TAVI procedure. And I think that's very important as soon as we start to receive the referral for these patients. From a procedural perspective, clearly, we also have things that we can do to reduce the risk of conduction disease itself. There's a difference between different devices as to the likelihood of requiring pacing. And there's also implantation techniques that we as operators can undertake to minimize the risk of conduction disease and pacemaker implantation. And you saw beautifully in Didier's case that certainly the use of the cusp overlap technique, in my opinion, should be mandatory now for several reasons. Firstly, for pacing, so that we try and achieve higher implants. We try to achieve a better understanding of the depth of our prosthesis into the left ventricular outflow tract with our areocaudal projection. That also has benefits, as you talked about in your talk, about the commissural alignment, but certainly procedurally we can hopefully achieve higher implants, thus minimizing the potential risk of conducting disease following the procedure. Certainly in my experience with the FlexNav device, the accuracy of positioning has been able to reduce the rate at which we have to put pacemakers in patients following their TAVI procedures.
So Dave, just before we go to the FlexNav system, for people who are using the classical LAO projection, and now we're talking about using the cusp overlap view, can you just explain what's the difference between those two implantation techniques? What does it offer you to change?
Absolutely. So I think it's key to understand from anatomy, and we all now use our CT scans to show the anatomy of the left ventricular outflow tract very nicely. And what we know from the LAO caudal 3 cusp projection is that the left ventricular outflow tract is very foreshortened. Therefore, we do not get an accurate assessment of the depth of our prosthesis into the left ventricular outflow tract. When we move over to a cusp overlap view in an areocaudal projection, the left ventricular outflow tract is much less foreshortened. We get a much clearer idea of where our prosthesis is likely to be in terms of depth into the left ventricular outflow tract. And as the bundle comes out between the non and right coronary cusps, it allows us to make a more accurate assessment and deliverance of a valve into the left ventricular outflow tract.
Yeah, so we can get a high implantation without the risk of a pop-out and thereby also lower conduction abnormality.
Absolutely.
So Tchétché, you and Nicholas just beautifully demonstrated how to use this FlexNav system. So can you just try to summarize the key features of the FlexNav system and how it actually helped you to optimize a TAVI procedure, again, with the use of minimum resources to vascular access and so on?
So clearly, if we are aiming in this difficult period to treating all the patients via femoral access, this is a type of delivery catheter that is superb and that perfectly fits the purposes. First, it's highly flexible. We can see that the coating of the overall delivery catheter is superb and it glides easily throughout the vasculature. It's really flexible. So you can, it wasn't the case in this case, but we had many patients with tortuous vessels and you can nicely track, and this is one of the most efficient, and I'm always honest when I talk about devices. In terms of negotiating bends and curves, this is one of the most efficient. It has a stability layer, and you can see that even in challenging cases, if you want to target high, you can, because this the device is going to be deployed exactly where you aim at in a very stable fashion. So
Tchétché, can you just
device appropriate for regular cases.
So what is the stability layer? What does that mean?
So it's an additional layer that is going to prevent the inner catheter from the frictions with the peripheral vasculature, meaning that when you retract the sheath, the capsule that contains the valve, the overall system is kind of disconnected with the peripheral vasculature. So everything remains stable and you are not biased by the curves, the calcium of the vessel, the aura of the patient. So this is a key feature that provides stability. And at last, we've seen that there is an integrated sheath, so definitely the profile is improved, and this is going to be beneficial for our patients.
Yeah. So, Dave, there's also a question about pacemaker rate with this portico system, the FlexNav system. Do we have any data on that?
Yeah, we do. We certainly have data from the IDE study, which showed the two systems, the first generation Portico and the FlexNav, and we saw virtual halving of pacemaker rates with the same groups of implanters in the US IDE study. We've also seen the same from the pooled analysis of the FlexNav data in 180 patients in both the US and Europe. And what we've seen is convincing reductions of pacing rates using the new delivery system. So the accuracy that Didier describes has been borne out in clinical practice with real world results.
Yeah. So as we move forward here, we were talking about this lifetime management of these patients, because of course we want to do a fast and efficient treatment, but we also have to look beyond the procedure itself and patient with longer life expectancy. Didier, is this a valve for a patient who's going to live for a long time with a valve?
Definitely yes, because several features of the stent frame, the overall scaffolding makes it appropriate for younger patients with longer life expectancy. Durability being put apart, we have open cell design that that keeps access to the coronary arteries. And if we think about the valve in the future, we could even imagine if we figure out how to align the commissures of another Portico device, we could imagine that, or even with another platform. So it's a device that nicely suits the purposes, the expectations for younger patients. It keeps the access to the coronary arteries, and it keeps the door open for TAVI in the future.
That's great. So I think it's time to wrap up this session here. So if I can just try to conclude what we've been discussing in the last hour here, we're seeing during this COVID-19 situation, the resources in the hospitals is very limited. We have to make sure that we have a streamlined but still safe and effective treatment of these patients. We have seen patients who early on had a surgical procedure is now instead of referred for a transcatheter procedure. The FlexNav system has several features. It's a very low profile system due to the integrated sheet. Didier was talking about the stability layer, which is preventing it from diving towards the left ventricle. And that in combination with a cusp overlap view, you can actually have a high implantation and thereby also a low rate of conduction abnormality. So I think this was, as I saw it, a great discussion. So thank you, Dave. Thank you, Didier, and also to Mauricio Taramasa, who was leading the chat function here. I hope you're going to enjoy the rest of the PCR eValve course. Thank you.